ECG interpretation isn't just about detecting heart attacks. It helps us understand a wide range of heart and body conditions. In this session, we'll move beyond ischemia to explore advanced ECG patterns that provide key medical insights. We'll look at pacemaker rhythms, electrolyte imbalances, and drug effects on ECG, as well as conditions like Brugada syndrome, long QT syndrome, pulmonary embolism, and pericarditis. These patterns can reveal serious problems that require quick action. The ECG is one of the most powerful tools in medicine. Let's continue building the skills to use it with confidence. Electrolyte imbalances. Hyperkalemia. Hyperkalemia profoundly affects cardiac conduction, initially causing peaked T waves, followed by PR prolongation, QRS widening, and, in severe cases, a sine wave pattern leading to cardiac arrest. ECG changes are directly proportional to potassium levels and require urgent correction. Electrolyte imbalances. Hypokalemia. Hypokalemia prolongs ventricular repolarization, resulting in flattened T waves, prominent U waves, and ST depression. Severe cases predispose to torsades de pointes, particularly in patients with concurrent QT prolonging medications. Calcium abnormalities. Hypercalcemia shortens the QT interval, while hypocalcemia prolongs it by extending the ST segment. These abnormalities influence cardiac excitability, potentially contributing to arrhythmias in critically ill patients. Other metabolic effects on ECG. Beyond electrolyte imbalances, various metabolic and systemic conditions significantly influence cardiac electrophysiology. Hypothermia produces a characteristic Osborn wave or J wave at the J point, along with bradycardia, prolonged QT interval, and atrial fibrillation at lower temperatures. Digoxin effect, seen in therapeutic doses, causes a scooped ST segment depression, while digoxin toxicity can induce life-threatening arrhythmias such as bidirectional ventricular tachycardia and atrioventricular block. Additionally, intracranial hemorrhage, particularly subarachnoid hemorrhage, may manifest with QT prolongation and deep, wide T-wave inversions, reflecting neurocardiogenic effects on myocardial repolarization. Recognizing these patterns prevents misdiagnosis and guides appropriate management. Drug effects on ECG. Numerous medications affect ECG morphology. QT prolonging drugs, including Class 1A as like quinidine, procainamide, and Class 3 as like amiodarone, sotalol, antiarrhythmics, along with certain antibiotics as like macrolides, fluoroquinolones, and antipsychotics, increase the risk of torsades de pointes. Sodium channel blockers, such as Class 1C antiarrhythmics, as like flecainide, propafenone, and tricyclic antidepressants, widen the QRS complex and may cause rightward axis deviation, particularly in toxicity. Understanding these drug-induced ECG changes is critical in avoiding iatrogenic complications. Pacemaker ECG Interpretation Basics. Pacemaker activity is represented on ECG by sharp vertical pacing spikes, which precede either P waves, that is atrial pacing, or QRS complexes, that is ventricular pacing. Modern bipolar leads produce subtle pacing artifacts, whereas older unipolar leads generate larger spikes. The QRS morphology varies depending on pacing site. Right ventricular apical pacing mimics LBBB, while biventricular pacing or cardiac resynchronization therapy often produces a RBBB-like pattern. Recognizing these pacing characteristics ensures accurate differentiation from pathologic rhythms. Pacemaker modes and ECG patterns. Different pacemaker settings produce distinct ECG patterns. VVI mode. Ventricular pacing with inhibition when intrinsic activity is detected. Appears as regularly spaced pacing spikes followed by wide QRS complexes with no P waves unless native conduction occurs. AAI mode. Atrial pacing with inhibition by intrinsic atrial activity. Characterized by atrial pacing spikes followed by normal QRS complexes, provided AV conduction is intact. DDD mode. Dual chamber pacing and sensing, maintaining AV synchrony. The ECG may show atrial spikes preceding P waves, and ventricular spikes preceding QRS complexes, mimicking physiological conduction. Correct interpretation of pacemaker function is essential to distinguish normal device operation from malfunction or pacemaker-mediated arrhythmias. Pacemaker malfunctions. Failure to capture. Failure to capture occurs when pacing spikes are present but fail to elicit cardiac depolarization, resulting in absent P waves, that is atrial pacing, or QRS complexes, that is ventricular pacing, after a spike. This can be caused by lead displacement, fibrosis at the lead tissue interface, battery depletion, or increased pacing threshold due to metabolic disturbances. If not promptly recognized, failure to capture may lead to severe bradycardia or asystole in pacemaker-dependent patients. Pacemaker malfunctions. Failure to sense. Failure to sense occurs when the pacemaker does not detect intrinsic cardiac activity and continues to deliver pacing impulses inappropriately. This can result in pacing spikes falling within native QRS complexes or on T waves, potentially triggering ventricular arrhythmias. Causes include lead malposition, insulation defects, electromagnetic interference, or inappropriate sensitivity settings. This malfunction requires urgent reprogramming or hardware evaluation to prevent complications. Pacemaker malfunctions. Failure to pace. In failure to pace, the pacemaker does not deliver output despite the absence of intrinsic cardiac activity. This can result in prolonged pauses or complete asystole in pacemaker-dependent individuals. Common causes include battery depletion, lead fractures, or oversensing of external signals, such as skeletal muscle activity or myopotentials. Prompt troubleshooting and device interrogation are required to prevent life-threatening consequences. Pacemaker-mediated tachycardia, or PMT. PMT is a reentrant arrhythmia involving retrograde P waves triggering atrial pacing, which subsequently triggers ventricular pacing, creating a continuous loop. On ECG, PMT appears as a regular, rapid rhythm, with consistent pacing spikes before each P wave and QRS complex. Management involves placing a magnet over the pacemaker to switch to an asynchronous mode, reprogramming the post-ventricular atrial refractory period, or PVARP, or activating PMT suppression algorithms to interrupt the tachycardia circuit. Repolarization abnormalities with pacemakers. Pacemaker-induced ventricular depolarization alters ST wave morphology, producing discordant ST changes, which is opposite to the QRS complex direction that mimic ischemic changes. Cardiac memory, a phenomenon seen after prolonged ventricular pacing, can cause persistent T-wave inversions in leads that previously showed paced QRS complexes, even after native conduction resumes. Awareness of these secondary repolarization abnormalities prevents misinterpretation as ischemia or infarction. Stress-induced cardiomyopathy or Takotsubo syndrome. Takotsubo syndrome, also known as broken heart syndrome, is a transient left ventricular dysfunction triggered by severe emotional or physical stress. ECG changes initially mimic anterior STEMI, with ST elevation in precordial leads, but coronary angiography reveals no obstructive coronary disease. As the condition evolves, T-wave inversions and QT prolongation develop, often persisting for weeks. Understanding this syndrome prevents unnecessary thrombolysis and ensures appropriate supportive management. Brugada pattern on ECG. Brugada syndrome is a genetic arrhythmogenic disorder associated with sudden cardiac death. The type 1 Brugada pattern, characterized by COVID ST segment elevation more than and equal to 2 mm in V1 to V3, followed by a negative T wave, is diagnostic and confers a high risk of ventricular fibrillation. Type 2 Brugada, with a saddleback ST elevation pattern, is less specific but warrants further evaluation. Recognition of this pattern is critical, as patients with a spontaneous type 1 Brugada ECG may require implantable cardioverter defibrillator or ICD therapy for sudden death prevention. Early repolarization pattern. Early repolarization, once considered a benign ECG variant, has been linked to an increased risk of arrhythmias in certain populations. The classic ECG features include J-point elevation more than and equal to 0.1 millivolt in at least two contiguous leads, notching or slurring of the terminal QRS complex, and concave ST segment elevation. While early repolarization is common in young, healthy individuals, inferior or inferolateral J-point elevation with a horizontal or descending ST segment may be associated with ventricular fibrillation. Nonspecific ST wave changes, mild T-wave flattening, minimal ST depression, or slight T-wave inversion, without a clear pattern often fall under the category of nonspecific ST wave changes. These can be caused by a variety of factors including electrolyte disturbances, medications, inflammation, and autonomic imbalances. Although often benign, their significance depends on the clinical context, emphasizing the importance of correlating ECG findings with symptoms and risk factors. Low QRS voltage. Low voltage is defined as QRS amplitudes less than or equal to 5 mm in limb leads, or less than or equal to 10 mm in precordial leads. Common causes include pericardial effusion, pleural effusions, chronic obstructive pulmonary disease or COPD, obesity, myxedema, and infiltrative cardiomyopathies such as amyloidosis. Recognizing this pattern prompts further investigation into underlying systemic or structural cardiac conditions. Electrical alternans. Total electrical alternans, where the amplitude of the entire PQRST complex varies from beat to beat, is highly specific for pericardial effusion with tamponade physiology. Repolarization alternans, limited to STT changes, suggest ventricular instability and an increased risk of arrhythmias. Identifying electrical alternans early can be life-saving, prompting urgent echocardiographic assessment and pericardiocentesis when indicated. Acute pericarditis. ECG evolution. Acute pericarditis is an inflammatory condition of the pericardium that produces characteristic ECG changes, evolving through 4 distinct stages. In the early stage, diffuse ST segment elevation is present across multiple leads, with PR segment depression serving as a distinguishing feature. Unlike STEMI, these changes are widespread and do not localize to a single vascular territory. As inflammation progresses, ST segments normalize and T waves become inverted, marking the subacute phase. In the final stage, the ECG may return to baseline, though some cases exhibit persistent T-wave inversions. Recognizing this progression is essential to avoid misdiagnosis and unnecessary thrombolytic therapy. Cardiac tamponade, ECG findings. Cardiac tamponade, a life-threatening condition resulting from excessive pericardial fluid accumulation, leads to compression of the heart and impaired diastolic filling. The ECG hallmark is electrical alternans, characterized by beat-to-beat variation in QRS amplitude, reflecting the heart's swinging motion within the effusion. Low QRS voltage is frequently present, along with sinus tachycardia due to compensatory mechanisms. Prompt recognition of these ECG findings, coupled with clinical assessment, necessitates urgent echocardiography and pericardiocentesis to relieve hemodynamic compromise. Constrictive pericarditis. ECG findings. In constrictive pericarditis, pericardial thickening and fibrosis restrict diastolic ventricular filling, producing subtle but important ECG changes. Low QRS voltage may be present due to reduced myocardial motion, and flattened or inverted P waves can indicate atrial involvement. Nonspecific STT wave changes, reflecting chronic inflammation and pericardial scarring, are common. While the ECG findings are not diagnostic alone, their presence in a patient with symptoms of right heart failure should prompt further imaging, such as echocardiography or cardiac MRI, to confirm the diagnosis. Computerized ECG analysis. Benefits and limitations. Modern ECG interpretation often involves automated computer algorithms, providing rapid preliminary assessments. These systems excel at rhythm analysis, interval measurement, and detecting gross abnormalities, making them valuable in high-volume clinical settings. However, they are not infallible. Misinterpretations are common, particularly with subtle ischemic changes, electrolyte disturbances, and paced rhythms. Over-reliance on automated readings can lead to diagnostic errors, underscoring the need for clinician oversight and manual ECG interpretation to ensure accuracy. Myocardial infarction with non-obstructive coronary arteries, or MINOCA. MINOCA refers to myocardial infarction occurring in the absence of significant coronary artery stenosis, presenting a diagnostic challenge. The ECG findings vary, often displaying ST elevation, ST depression, or T-wave abnormalities, mimicking traditional MI. Causes include coronary vasospasm, spontaneous coronary artery dissection, microvascular dysfunction, and embolic events. Given the heterogeneous nature of MINOCA, a comprehensive workup, including cardiac MRI and coronary angiography, is essential for accurate diagnosis and targeted management. Myocarditis on ECG. Acute myocarditis, an inflammatory condition of the myocardium, produces a diverse array of ECG abnormalities, often resembling acute coronary syndromes. ST segment elevation, T-wave inversion, and PR depression may be present, reflecting myocardial inflammation and injury. Conduction disturbances, such as first-degree AV block, bundle branch blocks, or ventricular arrhythmias, can occur in severe cases. Because ECG changes in myocarditis are nonspecific, elevated inflammatory markers, cardiac MRI, and endomyocardial biopsy may be required to establish a definitive diagnosis. COVID-19 cardiac manifestations on ECG. COVID-19 has been associated with a range of cardiovascular complications, including myocardial injury, myocarditis, pericarditis, and arrhythmias. ECG abnormalities may include diffuse ST segment elevation, which is pericarditis-like, T-wave inversions, and QT prolongation. The hypercoagulable state induced by COVID-19 increases the risk of pulmonary embolism and acute coronary syndromes, which may also present with ECG changes. In critically ill COVID-19 patients, continuous ECG monitoring is essential to detect arrhythmias and myocardial dysfunction early. ECG in pulmonary embolism. Pulmonary embolism can cause distinct ECG changes due to acute right ventricular strain and hypoxia. The S1Q3T3 pattern, characterized by a deep S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3, is a classic but non-sensitive finding. Other ECG changes include sinus tachycardia, right axis deviation, right bundle branch block, and T-wave inversions in V1 to V4. While ECG is not diagnostic for pulmonary embolism, its findings, when combined with clinical suspicion, can prompt urgent imaging such as CT pulmonary angiography. ECG in hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, characterized by myocardial hypertrophy and diastolic dysfunction, produces distinct ECG features. High-voltage QRS complexes, deep septal Q waves in lateral and inferior leads, and widespread T-wave inversions are common. Abnormal repolarization patterns, particularly in V4 to V6, may raise suspicion for apical HCM. The presence of pathologic Q waves and conduction delays suggests an increased risk of arrhythmic sudden cardiac death, necessitating close monitoring and, in select cases, implantable cardioverter defibrillator placement. ECG in athlete's heart. Athlete's heart refers to physiological adaptations in response to endurance training, often mimicking pathological ECG changes. Common findings include sinus bradycardia, first-degree AV block, early repolarization, and isolated QRS voltage criteria for LVH. However, abnormal T-wave inversions beyond V1, deep Q waves, or significant axis deviation may indicate underlying pathology, such as HCM or arrhythmogenic right ventricular cardiomyopathy. Differentiating between benign adaptations and pathological conditions is essential, particularly in athletes at risk for sudden cardiac death. ECG in long QT syndrome. Long QT syndrome is a disorder of delayed ventricular repolarization, predisposing individuals to torsades, depointes, and sudden cardiac death. The ECG hallmark is a QTC interval more than and equal to 480 milliseconds, with distinct T-wave morphologies depending on the genetic subtype. LQT1, broad-based T-waves, often exacerbated by exercise. LQT2, notched or biphasic T-waves triggered by emotional stress. LQT3, late-appearing T-waves associated with bradycardia-related events. Recognition of LQTS is critical, as treatment includes beta blockers, ICD placement, and avoidance of QT prolonging medications. ECG in Wolff-Parkinson-White or WPW syndrome. WPW syndrome is characterized by an accessory pathway or bundle of Kent that allows pre-excitation of the ventricles. The ECG features include a short PR interval, that is less than 120 milliseconds, a delta wave, that is slurred QRS upstroke, and a widened QRS complex. In symptomatic individuals, WPW can trigger supraventricular tachycardia or atrial fibrillation with rapid ventricular response, which may degenerate into ventricular fibrillation. Catheter ablation of the accessory pathway is often the definitive treatment. Therapeutic digoxin levels produce a characteristic scooped ST segment depression without significant clinical concern. However, toxicity can lead to junctional tachycardia, bidirectional ventricular tachycardia, or various degrees of AV block, requiring digoxin-specific antibody therapy in severe cases. ECG in tricyclic antidepressant or TCA overdose. TCA toxicity causes QRS widening, rightward axis deviation, and terminal R wave in AVR, reflecting sodium channel blockade. The severity of QRS prolongation correlates with the risk of ventricular arrhythmias and seizures, requiring sodium bicarbonate therapy as the mainstay of treatment. ECG interpretation is a cornerstone of cardiac diagnostics, allowing clinicians to detect ischemia, infarction, arrhythmias, and systemic disturbances. Mastering these principles ensures prompt recognition and appropriate intervention, ultimately improving patient outcomes. A systematic approach to ECG analysis, integrating clinical context, is essential for accuracy and effective decision-making.